presentations and discussions from our fantastic and esteemed panel. So I'm Sam Shah. I'm the Chief Medical Strategy Officer at Numan and Digital Health Research Lead at UCL Global Business School for Health. And I'm joined today by an amazing panel of people that many of you might know across the sector. We have Dr. Tashfeen Kholasi, who is a general dental practitioner, a CCIO, and the Vice President of the College of General Dentistry. We've got Vicky Chabla, who is an academic clinical fellow in dental and maxillofacial radiology and at Birmingham Community Healthcare NHS Trust. We've got Dr. Hatim Abdulhussein, who is the National Clinical Lead for AI Digital Medical Workforce at HEE, and also the Medical Director of one of the AHSNs. And of course, Andrew Dickenson, who is Chief Dental Officer for Wales and has of course got a big interest in digital and technology, and I'm sure will be sharing his insights from a policy perspective. So welcome everyone. So with that, I'm going to ask each of you to just briefly introduce yourselves in terms of what you do, but also tell us about your views and thoughts on digital dentistry. I'm going to start off with Tashvine. So Tashvine, over to you first of all.
Hey, hello everyone. Thank you for inviting me to this. Really honoured to be here with such amazing talent. My name is Dr. Tashfeen Kholasi. I'm a general dentist, but I have a very strong interest in digital dentistry. My previous path to dentistry was I did computer science and maths at university and worked in local authority working on interoperability projects. So I have a strong interest in how we connect systems together. I then decided to go down the dentistry pathway, but realised how disconnected as a profession we actually are with the rest of the health service, which led me to work in Health Education England as a clinical leader, a clinical fellow in leadership with HEE back in 2017, and that led me onto this path of being able to work with the NHS England, NHSX as the clinical lead in digital dentistry, where we delivered the first proof of concept that dentistry can be connected to the rest of healthcare. And we did that with urgent dental care and NHS 111. So we know that our suppliers in dentistry can connect to the wider system. And so we can do that data sharing piece where we're passing data from the health service into our dental services with, right patient name, right patient details, what their primary concerns are. And my other interest in the digital realm is actually around clinical safety and health IT. So I'm also a clinical safety officer for a couple of different organisations, and it's about how we clinically manage the data that we're passing and the systems that we're using to make sure that we're not introducing any harm or introducing any new hazards to how we manage our patients. So it's all about safety and health IT. That's where I think I'm going to stop for a moment and pass on to our next esteemed guest.
Thank you very much, Tashfeen. It's great to hear about your path from technology through to dentistry and now bringing it together. I'm next going to move over to Vinay. Vinay, please, can you tell us a bit about yourself, but also your thoughts and views on the sector?
Hi, my name is Vinay Chavda. I am currently an academic clinical fellow in dental and maxillofacial radiology at ST2 level. I actually got into dental radiology through my work as a TOEFL fellow, which was a HE funded program looking on the back of the TOEFL report, looking at the future of the healthcare workforce. Across all healthcare professions, but particularly I was focusing in dentistry. I'm recognizing that in dentistry, we use a lot of dental radiography to treat our patients almost every day. From that, I started a project looking at AI in dental radiography and dental radiology, and that's kind of how I ended up doing my job today and training to be a consultant in dental and maxillofacial radiology. I've got a few more slides, but I'll show you later on once we've done our introductions.
Feel free to share your slides at this stage, and yeah, please.
Okay, great. So I can it was easy for me to jot down my my points on the slide so that I don't forget anything. So yeah, this was the TOEFL fellowship, and this is kind of how I ended up getting my interest in digital technology and artificial intelligence in imaging in particular. So this table is a slightly out of date from 2019, but it shows that the ratio of acceptances and applications is just behind dentistry for artificial intelligence courses at university. These are UCAS figures that we use here, and it's actually above medicine as well. My other thing that I just want to bring up is that with all of these AI technologies is that there is a hype cycle, and this was first developed by Gartner, the management consultancy company. But where we are within dentistry, I think there is still quite an inflated expectation of what AI can do, and soon, and everyone on this talk will still be aware of some of the limitations of some of the digital technology, and I guess that's what we're here to talk about today. But my current area that I would like to reinforce is when we look at the number of published papers on PubMed, for instance. There's these two graphs that I pulled off the PubMed database yesterday. When we look at dentistry and implants, that actually peaked first in 2016. AI and dentistry has not yet peaked, and we're not nearly at the level of the published research that, for instance, dental implants have reached yet. And when I had a chat with the editor of the Journal of Dental and Maxillofacial Radiology, almost half the journal is now looking at AI and dental imaging, and they were now looking for a bioinformatician to go onto the editorial team to ensure that the research that is now being published is good quality. And that's, I think, something that we need to be aware of as dentists, to say what is coming out there in future. So that's where I'll stop. Thank you.
Really insightful, Vinay, and thanks for sharing those thoughts, especially having been one of the first Topol Fellows as a dental surgeon, but also now embarking on a pathway that very much touches on all parts of AI. So it's super helpful to hear those thoughts, and we'll come back to some of that in our discussion, especially around the Gartner hype cycle. And it sort of goes back to a point that Tashfeen made about the system as we see it. Well, next I will come on to Andrew Dickenson, Chief Dental Officer for Wales. Over to you, Andrew.
Sam, thanks very much, and it's a real pleasure to be sharing this webinar with everybody today. As you kindly introduced me, I'm currently Chief Dental Officer for Wales, but before that I worked for Health Education England as a postgraduate dental dean. And one of the real pleasures in my portfolio was to support the whole TEL team as it was developing and starting to move into the AI, robotics, digital and simulation field. And as you alluded at the beginning, I was not an expert in this, but it's amazing how quickly you upskill. And that led me to consider the whole concept about digital readiness. And from there, that led on to a paper which Hatim and I had published as a commentary in the British Dental Journal earlier this year, just to start that conversation. And I think that's probably some of us on this call have that role in terms of asking the questions, not being able to give any answers, but just to start getting the conversation flowing. And for me, digital readiness always sounds a very simple concept. And in dentistry, we have been early adopters of technology. But I think while technology is advancing at a really quick pace, at the same time, we have to keep thinking, is everybody coming on that journey at the same time? And it's probably an overused terminology, but we have a widening digital divide. And as we learned a lot through the events of the last couple of years, we've had to adopt technology a lot faster than we ever imagined. But does that really mean that we are ready? And when I say we, that's not just the profession, but also the patients that we're working with. And my worry is that the digital divide tends to focus on access to the digital technologies, whereas for me, readiness actually refers to the preparedness, such as, do we have the skills and do we have the trust in that technology, as this influences the adoption of digital tools, which for me, and it'd be nice to talk about this, I think is a very separate issue to access issues. I was taken recently by something that dropped through my front door from Lloyds Bank, and they've been doing a lot of work in the digital sphere. And they were saying in the UK, we have 99% internet coverage, but there's over a quarter of the population which actually fall into the lowest level of digital capability. And there's 4% of our population have no basic digital skills at all. They also showed, and this is why I read their document, is that 34% of the population actually struggle to interact with healthcare services. And this is where digital readiness is going to be really prominent over the coming years. The other conflict I have is people talk about digital literacy and healthcare literacy. And for me, that's almost a little bit of victim blaming, because the system hasn't actually adapted to allow people who are struggling with digital readiness to actually be supported. There's an assumption that it's up to them to go and learn this. So there were just 3 messages, Sam, I wanted to say about digital readiness, because I think there are 3 interconnected elements that might be helpful for our discussions. One is, do we have the digital skills? Are people actually able to initiate an online session, surf the internet, search for content in a meaningful way? Secondly, trust. Do they actually trust the information that they either read online, or do they trust the system? And then the third is usage. What do they actually use digital for? And interestingly, all 3 elements can actually be measured. That can either range from asking very simple questions. So in terms of digital skills, how confident are you getting on the internet? If you've got a new piece of electronic equipment, can you set it up, or do you need people to help you with? And certainly from a dentistry point of view, how confident are you with e-learning? I think these are very important questions that we can just start to measure people's preparedness. In terms of trust, that's really complicated. And as you alluded, there is a policy element in that. Is the infrastructure right? Are there systemic elements involved in all of this? It's okay saying we need to go online, but actually, are we providing people with the software, the hardware, the data security, the financial element behind all of that? And of course, we've got to overcome the usage element, which is there are some early adopters, there are some people who are the hesitant users, and there's some which are actually non-adopters yet. And we've got to think about how do we bring everybody in there. So if I just conclude, Sam, just my suggestion is that around digital readiness does require us to think a little bit differently and just move away from the technology adoption element. Let's have a look at the culture and the behavioural changes that are required, especially in healthcare, as we're moving patients into that sphere. There's the human adoption element, and that means that we've got to become more proficient, and that proficiency starts today. It starts through education. I signpost everybody to the HUE resource on the digital readiness education program. But in conclusion, we can actually measure people's digital readiness using a Metals digital readiness score, and that takes into account both our digital capability and our proficiency. And I think if we can think like that, then we've made a big step forward. So thanks very much.
Thank you, Andrew. I really do, and very much like the reference to the sort of the take on digital literacy, and actually we need to change the way we frame it. And I think you're absolutely right that yourself and other very senior leaders are there to ask the right questions and to get people to think about what we might mean and what we can do to change things for patients. And thank you also for mentioning the Lloyds Consumer Digital Index. For anyone that wants to read it, I've put the link into the chat there that you can follow up on. But in a moment, we'll come over to Hatim. And Hatim, you know, we've heard from Tashfeen about the disjointedness in the system, but also her journey through working in national organisations, trying to make a change in digital dentistry, but also how she came with a set of skills. We've heard from Vinay about the Topol Fellowship and the opportunities it brings, both in terms of his own work, but also what it means for the profession as a whole. And then we've heard from Andrew about the work around digital readiness and what that might mean, how we score people, the difference it makes. Andrew didn't mention the digital poverty in Carmarthenshire in Wales, where telehealth is almost non-existent. But Hatim, you've been leading on this programme, you've been running large parts of the system, and you have a role in innovation. It'd be great to hear from you about what people can access, but also your thoughts around innovation in healthcare.
Thanks, Sam. And I'm going to bring up a couple of slides, but whilst I do that, I think it's really important to say, as a practicing GP, oral health is essential, and it's really real pleasure to be around the table with oral health experts. But ultimately, as a generalist, you know, that is important for the wider workforce as well. I think outside of dentistry as well, we should all be thinking about how we promote oral health. We know it's linked towards cardiovascular disease and other general health outcomes. And then we know actually it's a really important factor in being able to just generally understand how well someone is, you know, coping in society and whether they need any further support. I mean, I've had the pleasure of working with our local primary care network, and, you know, we need to do more within primary care networks to bring general practice, dentistry, pharmacists and other healthcare professionals at that kind of level of care, at that neighborhood level, at that place-based level, together to be able to deliver outcomes that are going to make a difference. And well, technology is one way in which we can do that, and is one enabler to be able to allow us to do that. I'm going to provide a brief update on our digital AI and robotics in education program, and share, as Sam, you kindly mentioned, a couple of opportunities that are on the horizon. So I know some of the questions that have come in prior to the conversation today have talked about some of the factors that we know are going to impact on confidence in AI. So these are things around regulation, standards, liability, and we've got a previous webinar on that goes into more detail around how and what drives healthcare worker confidence in AI. So please do check that out. That was in webinar 3. And all of these are recorded on the Digital Academy website, which has been shared in the chat. And so just to highlight that we recently published a Developing Healthcare Worker Confidence in AI report, which talks about all of those levels, from a national level in terms of regulation standards, from a local level in terms of the local validation that's needed when you're delivering an AI or digital solution, and ultimately then at the coalface of that relationship with the patient. You know, how does a technology like AI impact on the way we make decisions and the way we interact with the people that we serve? And so if you want a little bit more reading and background information on that, please do check out those pieces of work. I'm really pleased to announce, and this is I think it's fantastic, that we are opening up the fellowships in clinical artificial intelligence to both medical and dental postgraduate learners. And this is the second cohort of the fellowship program. The first cohort was London, but the second cohort is wider than London. There are now posts in most regions of England. And so I'd encourage you to have a look at the website and find out more. If you are a dental learner that is currently in their SD3 year of specialty training, or is in a program which ends at SD3 and in their SD2 year, then you will be eligible to apply for these fellowship programs. And what's really unique about these clinical artificial intelligence programs is that it's an opportunity to do work that's AI deployment focused. So ultimately, it's moving away from some of the research and development, but actually being at the innovation space of, we're actually thinking about embedding some of these technologies and improving the care of the people that we serve through that. So it's a really interesting time and opportunity to join that program. Sadly, the Top Fellowship program is about to close for applications today. If someone is out there that is really keen to get an application in today, there is still time. But if not, I mean, I am pleased to say that in all cohorts, we've always had a representation from dentistry and oral health, and I hope that continues in the next cohort. And then next year, we will be relaunching the flagship NHS Care Digital Academy program around the Digital Health Leadership program, which Sam was on cohort 1 and a real trailblazer in this space. And so we hope that people will keep an eye out for that. If you are keen to, like Sam and like Tashfeen, move into really senior dental leadership roles around digital, that would be great to see. So just to highlight that these opportunities exist, they're open to our dental workforce out there, and I hope that you found hearing from the esteemed panel today really useful, and we look forward to answering some questions.
Thank you, Hatim, for that. That was brilliant. I was just going to say that I actually did in NHS Digital Academy as well. I was part of cohort 2, and so if anybody is considering applying for either TOEFL or one of these clinical fellows in AI, highly recommend it, because the 1 year that you spend thinking to yourself, "Oh, I'm going to step out of dentistry, clinical dentistry for a year," it will change the way you think about healthcare. So highly recommend it. Take the opportunity. If it doesn't work for you, that's okay. You know, you can always go back into clinical work because that's your bread and butter, but try something different. There's no harm.
That's a great plug, Tashfeen, because I think both yourself and Vinay have taken the courageous steps of doing things that are slightly different in a different pathway that have resulted in both of you being able to do some excellent things and have influence at a system level. So fantastic plug, and thank you. So now we're going to move over to questions, and we've got lots of questions already lined up, but I also would like people who have joined to ask questions. So what I would say is, if you'd like to ask a question, put yourself onto camera if you can, but either way, click on the reaction button so I can then see your name pop up in the participants, and I can then see that you want to ask a question. But I'm going to take the first question, and it goes first to Andrew, then to Tashfeen. We've got a question from Sammy Stagnor, and that question is about is the fragmentation of dental services an issue with collecting and implementing large data set solutions in primary care? Andrew, first I'll come to you, and then to Tashfeen.
Yeah, so brilliant starter question. I mean, data is key to everything that we do, is key to research, is key to development, is key to policy development. And I think we are moving in a new era where we need to understand how the care that we're delivering is having an effect at a population level. And at the current time, a lot of the data that we collect in primary care tends to be more transactional. It's around billing, it's appointment scheduling, document storage, and it could do a lot more than that. The fragmentation of dental services is an interesting element, because we are still siloed to a certain degree between primary, community and secondary care, and we have an insight into what each of those areas are doing, but it isn't a fluid flow of information between the three sectors. The other element around data collection are the large number of pieces of software that practices use as part of their practice management system. In Wales, we've got 14. In England, I think it's 25 or 26. And so straight away, some of those are inaccessible. Some are cloud, well, very few are cloud-based presently. Most of it requires a local server. So it's very difficult to extract data from those systems. So I think that is a real challenge to us. And of course, the question then is, do we start thinking in dentistry similar to general medical practice? Do we go for one or two pieces of software where you can have it all cloud-based, you can start extracting that information? And maybe this is where, when I was talking about digital readiness, we've got to be more trustworthy about the data. I think people are very suspicious sometimes when we're asking for data. We've got to be mindful that when we ask for data, it can be very time consuming for people to have to go and download it or put it into a format that can be used. So maybe that's where, as we go through the literacy and upskilling of practitioners, for example, into how to use data, we should also be asking, why are we using the data? What do we want it to do for us? But I think we can't. It's going to be difficult until we are probably more cloud-based.
Wow,
Tashfeen,
there's
what do you think?
lots in there. I mean, and Tashfeen, there's lots in there. There's a piece in there about interoperability, integration, data privacy, and trust, and of course, you know, the perennial issue that we face about those systems and where the data is held. Tashfeen, you've been a CCIO, you're a GDP, and you've been at the centre trying to piece this stuff together. What are your thoughts?
So I think the first question in my mind is, what's the problem we're trying to solve? You know, everyone's talking about AI and how it can do this amazing, all these amazing solutions to how we're going to provide care. But actually, what are we actually trying to solve? We have lots of data points in dentistry, I completely agree. We have lots of different systems, and they're in different parts of the dental health sector. And how do we connect that up? So that's the interoperability issue. We don't really have any standards with regards to interoperability for dentistry per se. There's been an attempt to use SNOMED, but actually, is that the way forward? Should we be using other forms of interoperability standards like HL7 and FHIR? And I think one of the things that we were trying to establish a few years ago was actually, let's get some common standards going so that we can have a digitally connected dentistry system. across the network from hospital services into primary care. We have a whole host of information just sitting in our systems in practice, and that can pick up anything from oral pathology to caries management if you're going to be looking at x-rays and imaging, to being able to plan things like orthodontic treatment. And you can use AI tools to be able to do that, but actually ultimately, and this is going back to what you were saying about digital readiness and how are we preparing our profession to go forward using technology. The other issue is that when we're talking about interoperability, is that we're often talking about how servers are connected and how we can process large chunks of data, but that's only half of the solution, because actually from a front end, we've got user interface, we've got users who will need to be using several different systems. And one of the hardest things and frustrating things as a clinician working in hospital and working in practice is actually when I have to log into multiple different systems to be able to access that data. So if I've got some AI running in the background that I'm going to help to use as an adjunct to my care, I want that to be integrated to whatever system I'm using to make that seamless workflow. So that's all part and parcel of what we're trying to achieve. And then my other issue is around clinical safety. I love clinical safety. I think it's really important.
What is clinical safety? What is it? Because a lot of people here will think of it in terms of what we do in practice. But what do you think of clinical safety as?
So clinical safety in health technology. So it's health IT. It's about ensuring that the data and the technology that we are using is safe to be able to be deployed into the services that we're using for safe patient care. So the data, so for example, you may have patient A comes in, they've been expecting to have some investigative tests, and they're expecting that data to be presented to them in a way that's usable and has got clinical significance, but actually through the pipeline that it's gone down to be able to get that investigation and that outcome, has something gone wrong with it? Has something fallen down? And just think of your Swiss cheese model, that error has basically penetrated through the technology to the degree that actually you've got a patient now that's been, for example, being told that they've got an oral cancer when actually they haven't. It's just that something's gone wrong in that pathway. So it's actually ensuring that the technology that we're using isn't introducing any new hazards, isn't falling down and causing problems. When it falls down, it should stop at that point. And making sure that the tools that we're using is providing the diagnosis that we're expecting and not introducing new harms.
Tashfeen, I think that's really helpful to highlight those particular things. And I was trying to get to the chat to put in the link to DCB 0129 and 0160, but I can't get into the chat. But if you can, do share the link so people can look those things up and understand clinical safety in health tech. Yeah. But health tech, oh, sorry, go on.
So I was going to say that that's an NHS digital standard, which is relevant to only in England. So Wales and Scotland, Ireland, is not relevant. However, the theory behind it is. So even though we don't necessarily have to use it in our allied countries, it's something that's definitely, there are clinical safety officers. So clinical safety officers has to be a clinician, has to understand how health IT works, has to understand the standards, and they then can become somebody that will then promote safe health IT in healthcare. And that's open to dentists as well. So as far as I know, I'm probably one of the few dentists who is a clinical safety officer in the UK. But as we grow, we're going to need more. So
absolutely, and I think a good call for people to join that section of the profession, and as we move into the world of AI and technology that will be AI driven as well, this will become increasingly important in the same way that it would be for a medical device. Which sort of takes us on to our next question, which is for Vinay. Vinay, this is about, this is Peter Bailey, who many of you might know, who has been working and leading on tech in a big provider organization. And what's your view towards X-ray-based AI technology in the marketplace at the moment? Something I'm sure you're very familiar with.
Yeah, absolutely. So, I mean, my last count, there were 14 companies worldwide which have got some sort of dental AI imaging algorithms which are open to market. Now, my thing with this, going back to the safety element, is that we are all GDC registered, and we are got to put our patients' best interest first. And there was, again, the word tool that was just brought up in the conversation. And essentially, AI imaging software interpretation is just another tool that we can use in our day-to-day practice to make our jobs easier, make them safer, make sure we don't miss anything for our patients. Now, with all tools, you can use them the right way or the wrong way. You can put a rotary endo file down a canal and fracture the file if you're not careful or safe enough. But that's similar with the artificial intelligence imaging algorithms. So if you're not sure on what you're looking at, or you're not sure on how the data is presented to you, you will make errors, and then you won't be putting your patient's best interest forward. So there is lots of availability out there. There's lots of companies out there who will be providing promotional information, promotional advertising for themselves, because it is a free market, which that's healthy, and that will build AI software out there. But as clinicians, we need to make sure that if we're going to procure this software, we do it correctly and through the right standards that are set out by UK standards. And we've got many regulators of digital technology, MHRA, CQC, all these different regulators to make sure that the software that we procure in our practice, because essentially, again, primary care are all separate, small individual companies, and they will procure different pieces of software, and whether that is AI imaging or whether that's dental software, electronic patient records, we want to make sure that we're doing the right thing for our patients. So how do we assess what's best? And I guess the answer is up to the regulators within this country, but there are lots out there. They are getting better slowly. There are still some errors, and again, that's when you need to assess the literature, assess what is being published, and be able to determine what is good and what is not good.
Vinay, that's really interesting, and particularly around that sort of issue around the evaluation and assessment. I'm in a moment bring Tashfeen back in on this, but just on that, a number of people who are on this call today and myself were in a discussion with Eric Topol earlier this week, and one of the things he referred to was the bias in data sets, especially when you're building AI. Are you worried about the risk that when we're building technology using AI in dentistry, inherently we're using a very biased data set? If we were to take an NHS data set, let's say in the UK, the population it comes from itself could be biased. Is this a worry for you?
Well, that's it. I mean, the age-old garbage in, garbage out kind of thing. So, like, yes, we all know that term, but what does it actually mean? One of the biggest cited papers in that Dental and Maxillofacial Radiology journal showed the AI numbering system of an OPG, but it got thrown very quickly when an implant was thrown in or a root canal treated tooth was thrown in. And it's very easy to throw off these algorithms if you've got something which has not been seen before. So if the algorithm was trained on a patient population where that type of implant has never been used in this country or not regulated to be used in this country, that will throw off that algorithm. So yes, absolutely. You've got variable demographics of patients and ethnic backgrounds in this country, which could absolutely throw off different pathology.
Tashfeen, you were going to come in there.
I was going to just mention about the regulatory aspect. So you're looking at software as a medical device, so the ISO standards. So any technology that you're planning on procuring, you need to make sure that they've got the right regulations and that they're meeting the right standards, because if they're not, that's when you're going to be bringing in inherent risk.
And is there anything in particular that you're finding is evolving at the moment for regulation in the UK, especially now with the change from Europe? Is there something that innovators should be aware of?
I think, again, software as a medical device, I think that's something that wasn't massively heard of in the past, but it's definitely something that's becoming more familiar. And I think as we're getting more and more entrants into the market, you need to be aware of that regulatory standard. You've also got things like the software development cycle that you should be adhering to for best practice. Because at the end of the day, when something goes wrong and you are audited by the regulators, then they are going to be looking to see what your processes were, and you need to be able to justify why you've done and what you've done to make sure that you've made things clinically safe.
I mean, Hatim, you probably have lots of innovators coming to you in the HSN and, of course, in HEE. What's your general advice to them when they're starting out and thinking about the standards they need to meet and the type of evaluation they need for a product, especially what could be in dentistry?
Yeah, look, it's a very difficult landscape to navigate, and it takes some time to truly understand it. And that's where the role of organizations like academic health science networks that have experience in running innovation exchange programs, have experience in working with small and medium enterprises to be able to overcome some of these challenges is really important. And getting set up on some of those kind of accelerators are really important to do. And our colleagues at NICE, MHRA have been doing some work in the background to really make this place as clear as possible. They've got a platform that they're currently piloting. It's in beta phase, and that will be a really useful platform to guide people that are working in this space to understand what kind of regulatory boundaries they need to overcome. There is an evidence standards framework for AI from NICE as well, which is really important because it starts to think about the type of evidence and the level of evidence you need to be able to overcome to be able to have a solution enter the market or enter the NHS. And so that's really important. And we are seeing transformation in this area. I think regulators are taking notice, but as with anything, these things take time. And so it's important to say that time is needed, because these are very sensitive matters. These are people's lives that we're dealing with. We know how important oral health is. We know how important avoiding bias in the way we make decisions is, and therefore we need to do these things safely, we need to do these things ethically, and we need to make sure that we have the right infrastructure.
Only the other day, when thinking about infrastructure, I was listening to the discussion on whole genome sequencing that's taking place and things like the use of CRISPR. But I won't bore you with that now. But I'm going to change tact and think about that framework. We know that technology is being used across the NHS already, advanced technology that's being used for genome sequencing. But in dentistry, we often don't even see some of those what now might seem as basic or routine technology emerge. I guess starting off with Andrew, we've seen extreme reality being used in maxillofacial surgery, where colleagues at King's and elsewhere have used the technology to plan surgery without having to necessarily start operating or have more precision around the type of device or implant they may place. What are your thoughts on the NHS framework, and can we really implement and utilise technology advances in the same way as other sectors? Are we really able to keep abreast of AI or other things in the NHS environment?
The simple answer is we can and we should, but the more complex answer is it's really difficult, and it's very difficult because as a professional group we're actually quite small compared to medicine. We tend to be almost primary care orientated, which is a really strong place for us to be if we were going to make a whole system change. But at the same time, we're also the majority are frontline clinicians, and therefore the opportunities to start looking at technology falls into their spare time. So you're absolutely right. A framework is that guidance, which is a yardstick for us all to aspire towards, but the adoption is going to be very different. And I think there are various policy areas around this. Number one is, if it's something that we really want, and I think we've all said this in our introductions, if it's something that we really want and we can answer that question honestly, what is it going to do for us? Then that's where we have to drive it through policy. We need to be funding this. The personalisation in medicine is going to come into dentistry, and we're starting to think like that. We're moving away as, again, our oral health is starting to improve. We're looking more at what can we do with our patients rather than what can we do for our patients. And technology is going to be perfect for that in terms of monitoring, supporting the patients. That more of that mHealth would come into the primary care situation. But I guess that's one of my other concerns, which I said at the beginning, is obviously when new technology starts to come along, we see it at conferences, we hear conference presentations, we get very excited and we go and spend money. And we buy something nice and shiny. I'm being cynical now, but we buy something nice and shiny, and then we don't utilize it to its full capability because we're not either using it for the right reason, or we don't have that level of practice where it's going to be adopted on a more regular basis. So you're quite right, in the secondary care, that's where advances have probably been driven a lot faster than primary care. But I strongly believe that if we can get what we're asking correct, and then we negotiate that appropriately through policy, then we've got a real opportunity to make substantial changes in the digital world within dentistry. But I think the caveat on that is we've got to have those open conversations about what is it that we want to do.
That really nicely sums up our session today, which comes to close in a few minutes. But I suppose, really to summarize that, I guess we need to avoid sort of searching for problems, for solutions that might exist, but really being problem focused around what is it we want to solve, what's the business benefit we want for the system, and what's the outcome we want for the patient. And certainly I'm, as many people know, a cynic of lots of things, but one of them is sometimes where we end up adopting technology for the sake of adopting technology. And I've certainly seen many of those over the years in the NHS and elsewhere. But that takes us to the end of our session today, and the questions and discussion probably could have carried on for a few more hours, but I'd like to take a moment to first of all thank Hatim and the team at HEE for putting this session together and the work that they're doing around digitization of the profession and professionalization, which is absolutely amazing in itself. Urge you all to look at the website and apply where you can. Thank you to our fantastic panel, to Tashfeen, to Vinay, and to Andrew for championing this this particular area of digital transformation, AI and data in dentistry. Please do keep it going. Let the conversation continue. But thank you very much to everyone for joining us today and your questions, and see you next time.
Thank you. And thanks, Sam, for an excellent sharing of